first one is going to be the AC compression test, or acromioclavicular joint test. So you got to know where your AC is. Your AC. Show off the gun, Scott. There we go. Okay, your AC is going to be right here. So your clavicular is here, your acromions up here. So all I'm going to do with this one, what I'm going to demonstrate on this one is I'm going to go ahead and push this joint together. You can actually put one hand down a little bit if you want, but what you're just going to be doing is pushing here on the joint itself. The sternoclavicular AC joint stress test is going to be patient sitting or lying, and so sternoclavicular is going to be here. So Scott's clavicle, you can kind of see it, but you can, right there. Sternum's here, so that's your SC joint, that's your sternoclavicular joint, that's your AC joint over here as well. I'm going to place one hand on the proximal end of his clavicle, which is here, and the other hand on the spine of the scapula, which is back here. And I'm going to apply inferior and posterior pressure on the clavicle. So I'll have to push down this way and back on the side. So I'm kind of pushing together. So this one's going to go down, and that one's going to go in. Go down and in. And you'll kind of notice the movement over there. Empty can test. The patient is going to stand. There we go. Face grace. Face grace. He's going to stand with both shoulders abducted to 90. Then we're going to horizontally adduct to 30. And we're going to internally rotate so the patient's thumbs face the floor. And what I'm going to ask Scott to do is he's going to try to abduct both shoulders. I know. So abduct is going to take away. So I kind of have to move here, Grace, so just bear with me. So I'm going to ask Scott I'm actually going to apply resistance to it, and I'm going to have Scott act like he's dumping the bottles down on the ground. So I'm going to push down, you push up. Okay. If he has weakness in one of the shoulders, it would go like this, or he would have a lack of control on it whenever we do this. Okay? That's your empty can. Jurgensen's test. The patient is sitting with the elbow flexed to 90 and the forearm at the lateral border of the radius. So we gotta look at our radius. This is the lateral border because this is your anatomical position. So this is lateral, this is medial. So I want that lateral border of the radius placing in the neutral position, which is this right here, where he's already at. I'm gonna stand on the involved side, and I'm gonna place one hand on his forearm and the other hand in the bicipital groove, which is right here. And I'm going to have him attempt to supinate the forearm and externally rotate the humerus. So what he's going to be doing is this motion is he's going to pull it over like that. He's going to externally rotate. This is supination. You're going to hold a cup of soup in your hand. So if Scott's starting here, he's going to go out this way. Okay? Ready? And go. And back. There you go. That's Jurgensen's test. The Speed's test. Patient is sitting with the shoulder flexed, so flexion, not that far, 90. Flex to 90, elbow fully extended, and the forearm supinated. So how is he going to turn his hand? Good job. And then I'm going to go ahead and say I'm going to place one hand on his forearm, the other hand on the bicipital groove, and I'm going to attempt he's going to attempt to actively flex the humerus forward. So he's going to attempt to go up, and I'm going to resist him. So go ahead. That's all you got to do. And when you resist them, you don't have to apply a large amount of resistance. Most people, when they think that they're going to resist them, they're like shoving them down. It's really just a moderate amount. Ludington's sign. Patient is going to sit or stand with their fingers interlocked on the posterior superior aspect. So he's going to put his hands back here, interlocked, like so. I'm going to stand behind him, and I'm going to palpate the long head of the biceps tendon, and I'm going to go ahead and ask him to apply force to the top of his head like he's pushing down. So actually put your head over there a little bit. And he's going to push down on his spine, and I'm just going to hold him in the bicipital groove. If he's having issues, he'll have pain right there. You can relax, Scott. You can relax. The drop arm test is probably about the easiest test that we can do. All I'm going to do is have Scott go ahead and raise his hands up all the way over your head and slowly lower them down. If he's having issues with his arm, so say his left arm is giving him pain, go ahead and back up to the top. If he's having pain with his left arm, he's going to start doing that. Go ahead and start lowering, and all of a sudden his arm's just going to fall down. That's an indication that he's having weakness and lack of motor control there. Hawkins-Kennedy impingement test. The patient is going to be sitting, upper extremities relaxed. I'm going to grab his elbow with one hand and the wrist with the other. I'm going to forward flex the shoulder to 90 and then internally rotate the shoulder. So I got to take him up here, and then I got to internally rotate. And that's all I'm going to do. So I'll take him from this motion up here and internally rotate him, which I probably should be able to get stretch.
Right there.
Piano key sign or spring test. Patient is going to be sitting with arm relaxed at his side, and I'm going to apply pressure to the distal clavicle in the inferior direction. So we're going to be looking over here at Scott's clavicle, and when I apply pressure on this part of his clavicle, we would see it kind of start moving on this side, like a piano key. Like when you press on one side of the piano key, the other side goes up. That's what essentially you're looking for here. Is if I push down the clavicle here, does it move over there? Which, not really, which is good. Anterior apprehension test. Patient is lying on the table with the involved shoulder, 90 degrees of abduction, and the elbow and 90 degrees flexion. I'm going to stand beside the patient supporting the humerus mid-shaft while the forearm is grasped proximal to wrist. And I'm going to slowly externally rotate the shoulder. So I'm going to do just like I am right here, and I'm just going to take Scott's shoulder and turn it out like so. Scott clunked, that's why we made that face. So I'm just going to externally rotate Scott. Okay. Put that back. Posterior apprehension. Patient is lying supine on the table. Examiner grasps the patient's elbow with one hand, stabilizes the shoulder with the other, and I'm going to get him to 90-90. And I'm going to internally rotate, but I'm going to apply a little bit of pressure. So I'm going to force his elbow kind of into the shoulder as I internally rotate. Remember, Scott's a baseball player. His internal rotation should be lacking. Most people are lacking anyway, but baseball players usually have an extreme deficit. Sulcus sign, long arm traction, inferior apprehension test. Patient is going to be sitting with arm hanging at his side. I'm going to stand lateral to him. I'm going to grasp the distal arm at the elbow and apply downward inferior traction force to the humerus. So what you're looking here is if Scott is having an instability issue, you're actually going to see a drop off here. So whenever I grab his arm, and you can stabilize here if you want, but you would see a big gap. Like you can see a little gap on Scott. So just look right around here. You see there?
Good, Scott.
But you can see right there, that's the top of his AC. So if it gets to be a large gap, then we're going to have issues with that. Does that bother you?
No.
Okay.
It doesn't hurt. I just feel the clump.
Yeah.
Like
There's some laxity there. Anterior drawer, we've heard these before, patient is supine. And we're going to stand next to caution. Place one hand on the humerus below the surgical neck, which is right around here. And the other hand is going to be on the scap and fingers behind the athlete. And while he abducts the long joint and forward flexes. This one is a pain in the butt, I'm not going to lie. So I've got to grab his scap back there. And then I've got to abduct the joint to 70-80. So this is a little far. Right here, forward flex, and then externally rotate. So I'm kind of taking Scott like that. So if you want to hear some pops and clicks, Scott's a good candidate right now. Okay? That's your anterior drawer, posterior drawer. Passively abduct the shoulder to 90. Sorry. See, I did it the wrong way. Abduct to 90. And horizontally flex the shoulder to 20 to 30. And I'm going to place the other hand posterior to the joint and internally rotate the humerus and apply downward pressure. So I'm going to go this way. Scott.
hear it?
You felt it.
Tell the
Job relocation. Patient is supine with the shoulder abducted to 90, elbow flexed to 90. I'm going to grasp the forearm, proximal of the wrist, opposite hand is placed over the humeral head, and I'm going to externally rotate the humerus until pain, discomfort, or all the above. So we're just going to take Scott and push him this way.
Are you having pain or discomfort?
no.
He seems to be okay with this one. So we can push down a little bit. It is the same thing. Alright. The grind test. Patient is lying with the shoulder abducted to 90 and elbow flexed to 90. Grasp the elbow with one hand and the proximal humerus. And what I'm essentially going to do is I'm going to shove his shoulder into the socket and I'm going to start trying to move it around. I'm just going to go back and forth and grind into that shoulder.
Is it clunky?
No.
Now the clunk test. Examiner places one hand on the posterior aspect of the humeral head and the other hand proximal to the patient's elbow along the distal humerus, and I'm going to abduct and externally rotate his arm overhead and apply anterior force. So we'll go overhead. And try to turn it. I don't like doing it that way. There we go. So we're gonna go over Scott's head. There we go. It clunks. So we're gonna take him up and over.
I heard a clunk.
You should, yeah. Scott clunks. Active compression O'Brien's test. So Scott's gonna sit up. Shoulder with 90 degrees forward flexion. And 30 to 40 horizontal adduction. So, hold on. 30 to 40 horizontal adduction. There. And maximal internal rotation. Turn it in all the way. And I'm going to hold, patient is going to horizontally adduct and flex the shoulder against the examiner's manual resistance. So what he's going to do is he's going to go this way and up. Okay, go ahead. And you're good. Okay. Absence maneuver, patient is sitting or standing. I'm going to put my hands, this is going to be a lot of thoracic outlet stuff. So I'm going to put my hand over here on his radial artery, which I should be able to feel the pulse real quick. Go. I'm going to externally rotate and extend the patient's arm while palpating the pulse. Then I'm going to ask him to extend and rotate his neck towards the arm and take a deep breath. So pull your head all the way up and then look towards your arm and take a deep breath. Also, we're looking here. All that we are looking for here is his pulse, and notice if it gets weak or not, because it did just fine. But that would be a sign of thoracic outlet syndrome. The Allen's test. Patient is sitting or standing with shoulder in 90 degrees abduction and external rotation. Elbow in 90 degrees of flexion. Hands over the radial pulse. Sorry, I'm having interim debate with myself. And then I'm going to have him turn his head away. Here we go. Here we go. Turn your head away. And you're checking for the pulse on this one too. Pulse is still there. If he has thoracic outlet syndrome, all of a sudden his pulse is going to diminish or go away or become very weak. For Allen, provocative elevation or the ruse test. The patient is sitting or standing with shoulders in 90 degrees abduction. Basically, this is what we call the chicken dance. So Scott's going to go like this, and you're going to tell him he needs to open and close his fingers for 3 minutes. We're not going to make Scott do it for 3 minutes. So you can relax. So a positive test would be inability to maintain that or with numbness or tingling. Military brace test, the patient is standing. And I'm going to grab his radial pulse and I'm going to actively extend and abduct the arm to 30 degrees. So I'm going to go here and out. pectoralis major contracture test. He's gonna lay supine with both hands behind his head, legs flat. And all I'm gonna do is what I'm gonna do is I'm gonna move his arms down. He's already pretty flat, so we won't have that much of an issue with it. But I'm gonna push his arms out. So we're really trying to make that pec stretch out. So Scott's pretty relaxed right now. If somebody was having issues with it, they wouldn't be able to go far with this. You can try putting him under something, pillow if you need to, but what we're gonna be trying to do is spread out his whole pec, out of his whole chest, that one. Crossover impingement test. Yep, sitting. One hand on the posterior aspect of the patient's shoulder, the other hand on his elbow. And I'm going to stabilize the trunk and then passively and maximally horizontally adduct the test shoulder. So I'm going to stabilize his trunk, maximally and horizontally adduct the test shoulder. Just going to go across. You click too much. So that's what I'm going to do with Scott. I'm just going to go across. The jerk test. Patient is lying with arm horizontally abducted and elbow flexed to 90. Sorry, trying not to get in your hair. I'm going to place the opposite, examiner stabilizes the opposite shoulder with one hand and places the other hand on the patient's involved elbow. And I'm going to force the head of the humerus into the glenoid fossa. So basically, I'm going to shove Scott's shoulder into himself.
What is this one?
This one is called the jerk test.
But you're not really jerking anything?
You skip some.
Yeah, I did. I'm going to force it in there, and then I'm going to horizontally adduct across. Like that. Near impingement, sitting or standing. Let's go again. Examiner grasps the patient's scapula posteriorly with one hand and the elbow anteriorly. And I'm going to passively and maximally forward flex the patient's shoulder. So you actually have to get your hands like right on his scap. And I'm pushing it. If you guys understood how much clicking is going on, you would know. And I'm just going to push it forward like that.
So does this mean that Scott has a lot of shoulder problems?
Scott's got a lot of issues. Okay, we're good.